Good evening, friends. I'll be talking on this topic short. Wish to thank e-governance for giving me an opportunity to conduct this training program for the 10-bed ICU project in Nagaland. So, as you would all agree, I think most of the listeners, this is an ultra basic topic that I'll be covering to address the knowledge deficit that may be present in the junior doctors who are working in ICU and some of the senior nurses. So it's a very important topic, and this is a common condition that one would see in ICU. And it is very important that you understand the nuances of this shock. So we'll just start with a case scenario because most of you will be dealing with the cases, and it is important to know as to how you go about managing this case. So 73-year-old female, so this is a garden variety case who comes with diabetes, hypertension, and who's had a total hip replacement 6 days ago, and she becomes oliguric, and the blood pressure is 130 by 100 millimeter, and she appears confused. So this would be a situation that you would normally see in ICU. And so what would be your interim thoughts about this? So oliguria is something that is there, but blood pressure, as you see, appears normal. Patient is confused and was added total hip replacement. And when you examine, this patient has mottling of the skin. So the question one needs to ask oneself is this patient in shock or is it a non-shock condition? So this is where I want the audience to have clarity. As I said, this is a very basic topic I'll be covering. So blood pressure is not the only indicator of shock because that is what I want the message to go loud and clear, that it is the tissue perfusion that gets compromised is what defines the shock. So when we talk about shock, the definition of shock is where your tissue perfusion is compromised. Here the skin perfusion is compromised and there was a mottling of the skin. So the whole definition of shock is not blood pressure. Blood pressure is one of the criteria, but blood pressure being low to a point of compromising the organ perfusion. So this patient may have been a hypertensive, and that blood pressure not necessarily may have been good enough. So shock is defined as, and skin is an important organ. So where your organ perfusion or tissue perfusion is compromised is what determines the shock. And capillary perfusion has to be less than skin capillary refill should be less than 2 seconds is normal. So anything more than 4 seconds is abnormal. So the message is, so look at the overall condition because this patient was oliguric, which means that kidney perfusion may have been compromised. Patient is confused, which means cerebral perfusion may have been compromised. And there was a mottling of the skin. So we cannot just see the blood pressure and say this patient is not in a shock. So that is the message I wanted to send. So there were three organs that were compromised: the skin, the cerebral status, and you had an oliguria. So not always. So this is a sort of a classic teaching that we do that blood pressure should be less than 90. So low blood pressure not always is a criteria for calling someone as a shock is the upfront message that I wanted to let you know. So when we say shock, why tissue perfusion gets compromised? So the tissue perfusion gets compromised because of two important components. One is low cardiac output. So that is what will cause impaired tissue perfusion. So this is a patient possibly who had a low cardiac output because she's a 73-year-old lady who had a total hip replacement and she had oliguria with confusion and with mottling. So low cardiac output, and when there is a low cardiac output, body has certain homeostasis mechanism which tends to maintain the blood pressure. So these two are important components, cardiac output and your perfusion pressures. What we say, both are needed to maintain adequate organ perfusion and to mitigate shock. So there is some sort of a balance that exists between the cardiac output and the perfusion pressure, which is blood pressure. And the balance is sort of maintained by certain homeostatic mechanisms. So the body tends to adapt to the compromise in the cardiac output by increasing the heart rate and by causing vasoconstriction to keep this balance. And when this balance gets overwhelmed, that is when a shock, when this compensatory mechanism gets overwhelmed, that is when patient gets into a shock situation. So it is a balance between your peripheral perfusion, cardiac output, and the compensatory mechanisms which are influenced by the heart rate and your vasoconstriction is what will maintain the integrity of the hemodynamics. And when these get overwhelmed, that is when the shock and shock is a reflection of the severity of the underlying disease. So this is what I want audience to understand. It is not only the blood pressure we see, we look at all the organ perfusion which determines that patient is in shock. So and lactate also is one of the metabolic indicators. And what are the determinants, clinical determinants of shock? I've just put it in a very simplified for all the nurses in Nagaland and doctors. Please don't undermine the value of clinical signs in determining the presence of shock. So I put it in a pictorial. Just remember this figure. So tachycardia is one of the indicators that there may be some sort of a precursor for a shock element. Low blood pressure is one of the clinical indicator. Low urine output, which is a reflective of organ perfusion, which is impaired to the kidney, is a marker of shock. And acidosis, if it is worsening with lactates going up. So you have to see whatever clinical indicators you have access to capture, please capture, and they are the determinants of shock. And lactate going up is an indicator of shock. And patients with dengue will have normal blood pressure, but you will see hematocrit being high. So there are certain disease specific conditions where certain markers are indicative of shock. So in dengue, it's the hematocrit which determines that there is a shock prevailing. And low end-tidal CO2, especially in a peri-op setting, is an indication of shock. Or low mixed venous saturation is an indication of shock, or impaired sensorium, which this lady, 73-year-old lady, is one of the indicator of shock. And someone having cold peripheries is a marker of shock. And in pancreatitis, we look at BUN, blood urea nitrogen, as one of the marker of fluid deficit. So that is also one of the marker of shock. And in dengue, again, we look at liver enzymes going up, and that also is one of the reflection of shock. And liver enzymes go up because of hepatic ischemia that sets in. So most of these, so you capture all these clinical indicators and make an assessment whether there are certain signs of shock that is affecting the patient, and then put it into the perspective. So what I'm only trying to say is only blood pressure is not the marker or a signal for shock. You have to capture all the variables and integrate these variables and determine if patient is in shock. Having said this, one has to again see, this is a 73-year-old diabetic, hypertension, and with a low cardiac output, with a low blood pressure. It is also important to see whether they are in a heart failure status or low cardiac, where they may have pedal edema, they may have basal crackers, they may have raised JVP. And these are all, so this doesn't mean that they are not in shock. So these again indicate that cardiac output is low. And these are also some of the features which tell you that there is a low cardiac output and your homeostatic mechanism is impaired, which leads to shock. So this is what I want you to understand. And these are the signs that one needs to pick up, which are all reflective of giving a signal as to the cause of shock. So one needs to understand certain global hemodynamic relationships. So in ICU, we always talk about hemodynamic status in terms of mean arterial pressure map. So this map is influenced by two important things. One is cardiac output. So you will be seeing QT. QT in all my slides will be cardiac output into total peripheral resistance, or the perfusion pressure needed for adequate organ perfusion. And cardiac output is determined by two entities. And each of you who are working in ICU needs to know that these are the influencers of hemodynamic status. So you need good cardiac output, you need good tissue peripheral resistance or perfusion pressure, and cardiac output is determined by heart rate and stroke volume. So now the question is, how, say, heart rate, obviously we can have some control. How do we influence stroke volume? So what are the things that influence stroke volume? And this is important for every ICU trainee or intensivist or ICU nurse. Stroke volume is influenced by three parameters, which is very important, which is preload, afterload, and myocardial contractility. So obviously, assessing myocardial contractility, you might have to do an echocardiogram. Afterload, you need advanced hemodynamic, but preload is something that you can determine clinically. So preload, you can look at JVP. As I said, if JVP is high, then preload is more. So CVP you can measure, which obviously for in our ICU parlance, we have underemphasized on CVP, or you can look at if you have pulmonary artery catheter, you can look at wedge pressure. But JVP is the easiest way to assess your preload, whether preload is more or preload is less, and so on and so forth. So coming back to the case, so this patient has had a heart rate of 104 and JVP was elevated for this patient and had cold peripheries. So why I am again revisiting these cases again goes on to show we need to determine what type of shock is it. So this is a patient who has a raised JVP, but there is organ perfusion that is impaired and cold periphery. So that's when you need to understand what are the types of shock that affects patients. So there are four types of shock. Actually, there are five types, but I won't talk about the fifth type, which is the anaphylactic shock. So first is the cardiac. So in cardiac, this is very important for all the nurses. Generally, you have to look at three aspects. So heart rate can be high or it can be low in cardiac, especially when they have sort of a bradyarrhythmias or a thick sinus and so on and so forth. Heart rate can be low, but very often the heart rate will be more. JVP will be elevated, or CVP or left ventricular filling pressure or pulmonary artery occlusive pressure will be high. Peripheries will be cold. So this is an important aspect that one needs to keep in mind with when you're dealing with cardiogenic shock or cardiac failure causing the shock. When it comes to hypovolemia, it is fairly intuitive that any patient you see with severe tachycardia, one has to keep in mind there may be hypovolemia. And JVP will not be elevated in hypovolemia, and peripheries will be cold, even in hypovolemia, or sometimes it can be normal. The third important shock that we see in ICU is septic shock. Septic shock, again, heart rate, there'll be tachycardia. JVP can be normal, and peripheries in septic shock will be warm. That's why in every ICU round, it is important a nurse or a doctor should feel the peripheries, because very of even today, even in the tertiary referral hospital that I work in, where all modern procedures are done, we always, even cardiologists, and we feel the peripheries. And almost always it gives us an answer. If it is cold, then you know we are not dealing with septic shock. If it is warm, then we know there is a overriding shock is caused due to the infection. So warm peripheries will give you that cue. So this patient with a raised JVP and cold peripheries is definitely telling us that he's not in sepsis. So the pointers are more towards cardiogenic shock, right? Or obstructive shock. So the fourth shock is obstructive shock. Even in obstructive shock, all shock, heart rate will be high. In obstructive shock, also JVP can be high, peripheries are cold. So when you look at these four types of shock, so it's very easy now to put this patient into some category. Either we have to put it in cardiac because heart rate is high, JVP is elevated, cold peripheries. It cannot be hypovolemia because JVP is elevated. It cannot be septic because peripheries are cold. So, or it has to be obstructive because this patient has had that total hip replacement. So, this patient is at a risk for developing pulmonary embolism. So, that is something you have to keep in mind. So, for all the trainees, please remember these are the four types of shock that one should keep in mind. Again, coming to case one, heart rate is 104, cold peripheries, raised JVP. So now we have delineated, we have ruled out septic shock, we have ruled out hypovolemic. So now we have to determine whether it's cardiogenic or obstructive shock because this patient is at a risk of developing pulmonary embolism. So what would you do next? Because this patient has hypoperfusion that is setting in. So you have to start resuscitative measures and start some vasopressors to optimize the hemodynamic status. And would you give fluid because JP was elevated, cold peripheries, and you don't know if it may be obstructive shock. So the whole debate or the question would be how much fluid would you give, and what is the type of fluid you give, and what are the targets that you would have. So you need certain hemodynamic parameters to determine whether they are fluid responsive. So that is what one needs to have some understanding. So the treatment goals is obviously to optimize cardiac output and optimize the blood pressure or the perfusion pressure. So one needs to understand the perfusion. Why we are talking so much about perfusion pressure? Because the perfusion pressure or blood pressure has a good correlation with the tissue perfusion or the blood flow. When I say perfusion pressure, blood pressure having a reasonably good correlation with the blood flow to the organs. And there is there is auto-regulatory mechanism. As I mentioned, there is an internal homeostasis because at certain level of blood pressure, there is a good homeostasis of good organ perfusion with whatever vasoconstriction and heart rate, there is good perfusion maintained. But below certain autoregulatory levels, there will be a severe compromise in the organ perfusion. That is when the shock sets in. So what we are trying to say is, in the blood pressure or the perfusion pressure for every individual has certain range in which there is good auto-regulatory mechanisms which are optimizing good organ perfusion, which gets compromised when blood pressure falls after certain level. then even your blood flow also tends to get terribly compromised. So that is what we need to be aware. So, so here, case one, this patient has become hypotensive. So fluid, it is like if patient has no crackles and patient is very hypotensive, small allocate is something you can give to see if there is responsiveness. But if they have crackles and if they're hypoxemic, obviously you would not give fluids. You have to start vasopressors upfront. Please give oxygen. So any shock, they would need oxygen. And one has to, after resuscitation with vasopressors, oxygen, and plus or minus fluid, you have to start or doing investigations. For all the nurses, the one important investigation which will upfront tell you how sick the patient is or how severe the shock is arterial blood gas, because that will tell you lactate level, that will give you hypoxemic level, that will give you acid base levels, and that will give you hemoglobin, and so on and so forth. So ABG is something that even in my ICU rounds, I tell everyone, one look at ABG to tell me whether this patient needs to be prioritized or we could sit on that patient. And obviously, you have to do ECG for this patient because of whatever changes that we saw. And you have to send all the blood investigations, which include CBC, KFT, coagulation, so on and so forth. So this is the basic approach to the shock with regards to investigation. So this ECG of this patient that was done shows this. So obviously you see there is a huge FT elevation in the anterior lead. So this patient possibly has had an anterior wall MI. So here, now the sort of debate we would have between the thought process, is this patient needs fluids, she's becoming hypotensive, and considering that she doesn't have crackles. So we talk about a concept called fluid responsiveness. So what do we understand by fluid? Fluid responsiveness is a physiological state where by administering 100 ml fluids for this, whether we are able to improve the cardiac output, because cardiac output can be increased by only heart rate, stroke volume. Stroke volume, what is stroke volume? Determined by preload, afterload, and contractility. So afterload, if it's not an issue, then contractility has to be optimized with your vasopressors and inotropes. And volume status also has an influence on improving the stroke volume. So one thing we understand is too less fluid is harmful, too much fluid also is harmful. And why we talk about fluid responsiveness, when to understand this, we need to understand Frank Starling's law. See, this is a beautiful graph which really tells you, see, this is the red line is a patient with a cardiac dysfunction. In patients with cardiac dysfunction, so you see the fluid responsiveness is blunted and you start having improvement in the stroke volume until certain level. After that, even after whatever additional administration of fluid, so there would not be increase in the cardiac output. And this gets even more compromised in patients with cardiac dysfunction. So the red curve is patients with cardiac dysfunction. The blue curve is the patient with a normal. So as you see, someone with a normal cardiac function has an ability to respond to increasing fluid boluses at a much better in a much better way as opposed to someone with a depressed cardiac function. So this patient is with a depressed, but even patient with depressed cardiac function has some ability to respond to some fluid. That's where we talk about concept of mini fluid. But so that's why now any approach to shock mandate at the outset doing an echocardiogram to determine what is the cardiac status. Because if cardiac function is normal, then their ability to respond to the larger fluid bolus is much better, as opposed to patients with a depressed cardiac function where the response to the fluid bolus is blunted. And that's why we talk about mini fluid bolus in this to see. We do not know if this patient is hypotensive, whether this patient is in this part of the Frank Sterling curve or in this part. So that is where we give little fluid bolus to see whether there is response. So when should we test fluid response? When there is obvious hypovolemia, we don't need to do all this. And if there is septic shock, hypovolemic, we don't check for indices, because in this talk, I'm not going to deliberate on the tools for fluid responsiveness, but we don't test for fluid responsiveness when there is obvious hypovolemia or obvious septic shock or hypovolemia. We check for fluid responsiveness when we have a dilemma in a patient who is euvolemic, like hemodynamic instability is present, but you have your capillary refill which is not happening, like this case, and where oliguria is there, where you have a lactate going up or thermal modeling, and you have a high JVP. These are the patients who are challenging for us to determine whether they respond to the fluid. This is where we need advanced hemodynamic variables like pulse pressure variation, passive leg raising, stroke volume variation, so on and so forth. That's a separate talk in itself. So these are the subgroup of patients where we need certain advanced hemodynamic maneuver to determine fluid responsiveness. And even with this, even if you have ascertained fluid responsiveness, only half of the patients respond to the fluid. So this is what the literature tells us, because not every patient would respond to the fluid the way we would want. So now the question is, what if fluids aren't enough? So, so if you are in a situation where you have a low cardiac output and low blood pressure, if patient has a low cardiac output, the choice of the vasopressor or the inotrope is inotropes. So what are the types of inotropes that we have? And if your intent is only to improve perfusion pressure, then we start vasopressor, which is norepinephrine. Inotropes, there are two types, dopamine and dobutamine. So dopamine is inotrope plus vasopressors. It increases the blood pressure, it has inotropic effect, and it has chronotrope, it can increase the heart rate. Dobutamine is inotrope and it's a vasodilator. So especially in hypotensive, one has to be careful while giving dobutamine because it vasodilates and blood pressure can fall. And it is very dangerous to give, especially in the setting of hypovolemia. If they are euvolemic, dobutamine can be carefully titrated. And it is a chronotrope, it can increase the heart rate. And vasopressor, the common one that are used is norepinephrine. There is another agent called vasopressin. So one should bear in mind this patient, considering anti-wall MI and it's a low cardiac output, one has to keep an eye on the diastolic blood pressure, because diastolic blood pressure is what is needed for good coronary perfusion. And your LV function or contractility is determined by your good coronary perfusion. And heart rate also has a influence on your adequate coronary. If patient is very tachycardic, there is shortening of the diastole and coronary perfusion gets compromised. That is where the tenets of managing this patient is to make sure your diastolic blood pressure is optimized so that your LV contractility is better with adequate coronary perfusion, lessen the heart rate by increasing the duration of diastole. So these are the principles that one should keep in mind when you're addressing a patient of this nature. So now the question is, you have chosen that you have to start inotrope and with a vasopressor, how much would you give? So in all the critically ill patients, the dose response is shifted down and to the right. So there is an altered dose response, which means there is no fixed dose of any of these drugs, and the half-life of all these vasopressors or inotropes is very short. It's only 2 to 3 minutes, and all these drugs have to be titrated to the effect, and the dose that is needed for each critically ill patient can be quite variable, and it has to be titrated to the effect is what one should keep. And there are no fixed doses. So that is something I want to be clear and loud, that there are, we say you can't give more than 20 micrograms, 10 micrograms. All these are very fluidic in nature, and one has to titrate to the effect. And in cardiogenic, so considering this patient is cardiogenic shock, once you have resuscitated, especially in a place where cardiologist may not be there, this patient has to be referred to a place where other organ support, like this patient may need intra-aortic balloon pump, and definitive revascularization and percutaneous intervention has to be performed to influence good outcome. So this patient has to be referred to a place where percutaneous intervention and balloon pump support and so on and so forth can be utilized. So that's about this case, what we discussed about the cardiogenic shock. And now we'll just slowly move to the hypovolemic shock. These are very simple. I'll just finish in next 3, 4 slides. So just pictorially showing you hypovolemic shock, there is fall in volume and there is low intravascular volume. And 10% loss of volume does not lead to signs and symptoms of shock. For the shock to manifest, there should be 30% loss of intravascular volume to manifest the signs and features of shock. And hypovolemia, the only sort of a elixir is fluid. So fluids to be administered to replenish the volume and treat the underlying cause. When I say treat, if patient is hypovolemia due to diarrhea, obviously you have to treat a diarrhea. If patient is hypovolemia due to blood loss, you have to give blood, give volume, and obviously attain good hemostasis to prevent ongoing bleed. So hypovolemia is simple. And they'll have tachycardia, they'll have cold peripheries, and the heart rate will be high, so on and so forth. Um, so that's about hypovolemia. So septic shock, I think you can see the difference here. Septic shock is a double whammy. So alongst with the fluid deficit, there is a vasodilation. So that is the hallmark of septic shock. So they would have a vasodilation, and the treatment TNETs would be again the fluid resuscitation with vasopressor. And in addition to this, the most important is the source control in septic shock and administration of antibiotics. And inotropes also may be needed in septic shock, especially when they have septic myocardial dysfunction, which is something that happens in severe sepsis. So we have to assess cardiac function even in sepsis, and then if there are features of myocardial dysfunction, inotrope has to be considered in septic shock. So just last slide on obstructive shock. So obstructive shock is a little complicated because the causes can be variable. This patient could have had obstructive shock due to pulmonary embolism. Pneumothorax is something which can cause obstructive shock. So you have to drain the air out by putting intercostal drain or needle thoracocentesis to improve the shock. And if it is a pulmonary thromboembolism, massive PE causing sort of a shock, so thrombolysis and percutaneous thrombectomy, so on and so forth, should be thought of in as an advanced measure. And even here, minimal fluid allocates with vasopressors remain the TNETs. And obviously, you call for help from an expert to treat the underlying cause, would be the way to look. So the summary, so remember this picture. So look at all the valuable clinical indicators that tell you if patient is in shock. And these are all the simple bedside clinical indicators that one can look at. Fall in heart rate, fall in the blood pressure. And these are all the features that you see for improvement in the shock. So whether heart rate is coming down, blood pressure is going up, whether urine output is improving, acidosis is improving, lactate is coming down, and hematocrit is falling down, especially in dengue. Liver enzymes are getting better. In pancreatitis, it's the blood bun which is coming down. Warm peripheries, improvement in the sensorium, improvement in the mixed venous saturation, improvement in the integral. So these are all the simple clinical tools that you can keep in mind to determine whether your patient is getting better from shock. Fluids remain the mainstay with vasopressors plus or minus inotropes are the mainstay for addressing the shock. Most importantly, treat the underlying cause. So these are the take-home messages. So thank you one and all. So I request all of you, if you are doing some good work, present to our journal. So I'm one of the editors for this. So we will consider your uh, valuable work favorably to publish in our journal. You can visit my website www.drpradeeprangappa.com to rehear to this lecture. So thank you one and all. I'm happy to take the questions. So thank you one and all.